Hi, good evening, everybody. This is Tracy from Lynch Syndrome UK. This evening we have a talk from Dr. Neil Ryan, an absolutely amazing gynecologist who is very, very knowledgeable on Lynch syndrome in ladies. So welcome, Neil, and over to you.
Thank you very much. And apologies about the delay. I was having a few technical issues. And hello, Lynchies. It's a real absolute pleasure to speak to you guys. Lynch Syndrome UK is one of the most incredible organisations, and what you guys do is fantastic. And to just have a forum and a support group for what is a really hard condition to find out you have, and then to live with and to negotiate is exceptional. And it's important to do it together. And I think when I first had the honour of speaking to Lynch Syndrome UK, I said that, you know, from the medical side of things, we're very sorry. And I think that it's really important to recognise that a lot of the time we let you down. And one of the specialties that let you down quite a lot historically is gynaecology. I'm hoping that I can make the argument that we're trying to fix that problem now, but I really hear from lots of women with Lynch syndrome about how they approach their gynaecologists or approach their general practitioners and they just get a wall of confusion, silence, incorrect information. So we're trying to get that better. We're trying to make that less frequent. And I'm hoping that this talk will give you some information that means that you can go to your GPs and to your gynecologists a bit armed, a bit forewarned, and ready to sort of take them on if they're not doing what they should be doing. Okay, so what we're going to talk about? Well, first of all, I'm going to talk about finding people with Lynch syndrome within the specialty of gynecology, diagnosing Lynch syndrome by gynecologists, which is something that historically, again, we've just not done. So we always thought it was colorectal. We've left it to the colorectal surgeons to work it out. And we've not really taken a forward position on this. And I'm hoping, talking you through what we've achieved over the last couple of years, it now is the gynecologist realm as well. We should be identifying people with Lynch syndrome, and we should be making those referrals, doing those tests and explaining those tests to you, and also consenting people for testing for Lynch syndrome. Because if we don't find it, we can't do anything about it. And you're just left with that risk, but with complete ignorance, and that's not acceptable. The next part of the talk will be about caring for women with Lynch syndrome. So obviously that really focuses on women who haven't yet had an ovarian or endometrial cancer associated with their Lynch syndrome, but have been diagnosed with Lynch syndrome, and how to manage that cancer risk. And then I'm going to talk a little bit about future directions. And those are areas that myself and Professor Emma Crosby in Manchester are working on. Some of these slides are hot off the press, and some of them haven't even made press yet. So it'll just be talking about what our ideas are, how we can do more, do better. So in this talk, there will be discussion about germline and about somatic. And I still, you know, I think this is a confusing thing for medics, let alone for people who are sort of facing this without a medical degree. So germline talks about the genes that you have that you pass on to your children. So that's what germline means. It's the inheritable genes. So not all of your genes in your body you pass on to your children. So that's what germline is. Somatic are the genes within your cells within your body that you don't pass on. So it's quite funny to think, but some of the cells in your body will have different genes or mutations within them to the rest of your body. And that's very important when we talk about cancers, because cancers are genetically different to us. And that's why they're cancers. So they've got mutations, they've got changes in their DNA that mean that they are separate to your genome, your genes and DNA and etc. So that's what it is. So if I'm talking about somatic, if I drop that word in, I'm probably talking about a cancer. And if I'm talking about germline, I'm probably talking about something inheritable, i.e. Lynch syndrome in this instance. So I think it's helpful just to go through what is actually going on in Lynch syndrome and what is going on in cancers that have Lynch syndrome. And what I mean by that is that cancers can develop Lynch syndrome in their own way. So that means that it's separate to somebody having Lynch syndrome in their body, but that cancer has acquired a mismatch repair error. That means the little thing I'm about to talk you through, and it develops Lynch syndrome, but the person may not have Lynch syndrome. So let's just talk about that a bit more broadly. So when you have a cell that's trying to make a new copy of itself, and that's what cells do all the time, they're always copying themselves, they're always generating new cells. They copy DNA that's in their parent cell. So it's just like, you know, if you think about children, you've got a cell that's making children, and the way that it does that is it makes a clone of itself. And what can sometimes happen is errors happen. It's almost like when you're writing out 500 lines. If you keep writing, you know, enough text and you're copying it from one book and you're writing it into a new book, you're probably going to make a mistake at some point. And so what we call this is a mismatch error. It's whereby the two DNA bases, the two letters in the DNA, aren't going together in the way that they should. So here we've got gin and tonic, G and T, my favorite drink, but actually in DNA, G and T shouldn't go together. It should be A and T. So what happens in cells that don't have Lynch syndrome, or in people that haven't got a cell that's developed Lynch syndrome, is that the mismatch repair system works. And the first part of the mismatch repair system are two proteins, MSH2 and MSH6. And you might recognize these as, you know, mutations that you guys have. So some of you might be like, I'm a Lynchy with MSH2, I'm a Lynchy with MSH6. And what that's actually talking about are these proteins that are working within the cells to repair DNA if there's an error when that cell's been made. So the first thing that happens is that these two proteins, which have come from the genes, come along, they say, this doesn't look right. There's a problem here. G and T shouldn't go together. And what they do is they recruit their buddies along. So MLH1 and PMS2, and again, you'll recognize those as genes that we associate with Lynch syndrome. And what those two proteins do is they cut out the spelling error. They put the TipX on the DNA and say, no, that's not right, TipX that out. That means that the person writing it again can write over the TipX, and the person writing it in your DNA is something called DNA polymerase. Don't worry too much about this. So what happens is, in the end, if your mismatch repair system's working well, you have an error. That error is spotted by the first two proteins, MSH2 and MSH6. It's TipX'd out by MLH1 and PMS2, and then it's written over the TipX correctly by this other thing. And that's important because that's the main issue within Lynch syndrome, is that this system isn't working. So you get lots of spelling mistakes within your DNA. And then sometimes cancers develop this problem and they get spelling mistakes, and they develop lots of spelling mistakes, which can sometimes be very bad for the cancer, but rarely means that they start developing superpowers that makes that cancer more concerning. Okay. So let's just talk about a little bit about the history of Lynch syndrome. I'm sure you guys are quite familiar with this. This is Wolflin up here, and this is Lynch down here. Both are looking quite stern, great eyewear choices. Middle parting is a dubious choice, I would have to say. But, you know, can't judge him, 1800s. The thing I wanted you to take away from this is what we call a pedigree. This is when someone draws out your family history in a medici way. And if you look, cancer of the uterus here, cancer of the uterus here, cancer of the uterus here, cancer of the uterus here. When Lynch syndrome was first described, it is full of womb cancers and ovarian cancers as well, cancers of the ovary. So Lynch syndrome was a gynecological problem. It's just that we never recognized it as gynecologists. And then if you go down to the family tree that Lynch himself wrote out back in the 60s, again, lots of womb cancers and ovarian cancers, but it always seemed to be that we focused on the bowel cancers. And that let gynecologists off the hook because we were just sort of oblivious to it. We ignored it. We didn't really know anything about it. But I just want to highlight the fact that actually from the very beginning, the cancers that we were seeing were gynecological. And so this has always been a gynecological condition too. Okay, what is Lynch syndrome? So this is an infographic that we recently produced, and we put it in what's called the Obstetrician and Gynecologist, which is a professional journal that is produced for gynecologists and obstetricians to read, and it's like their update. And the reason we wanted to make it nice and simple is that gynecologists are very simple. We're not very complicated creatures. We need pictures and we need hard, quick facts. So we know that what Lynch syndrome is, you know what Lynch syndrome is, but the most important thing is that 1 in 278 people are affected by it. That's insane. You can imagine 300 people and one person in there has Lynch syndrome. It's crazy. The thing that is really scary is that 95% of people with Lynch syndrome don't know they have it. So we haven't found these people. We haven't diagnosed them, and we haven't started to prevent their cancer risk or reduce their cancer risk by doing things. So these people are just walking around with Lynch syndrome, unaware they have it, with this increased risk of cancer, and no one is doing anything about it because we don't know they've got it. So why should we look for Lynch syndrome? as gynecologists? Well, first of all, because it's very common, and because if we can find people with Lynch syndrome, we can do stuff. Okay, so I think just a little way about how we test for Lynch syndrome, because again, I think some of this stuff is a bit sort of like, bit sciencey, bit sort of, but actually it's all really simple. And what you'll find is that scientists and doctors and all sorts of people try and use big words and fancy language, but actually what we're doing is usually quite straightforward. So there's two ways of testing for Lynch syndrome if you just don't test the person. So one option is just to take a sample of their blood and then test their genes to see if they've got Lynch syndrome. We call that germline testing. Remembering that word germline, meaning the genes you can inherit. The other way, if you are looking for people with Lynch syndrome who've got cancers, is you can take a sample of the cancer and you can do what's called microsatellite testing, which is what this is, or you can stain the tumor for the proteins that we just talked about, MLH1, MSH2, MSH6, and PMS2. And if the protein doesn't stain, then they don't have a protein there, which means that they could have Lynch syndrome. So this is what we call immunohistochemistry, big posh word. This is what we call microsatellite instability, but both of them are ways of testing a tumor to see if the person might have Lynch syndrome. We then run it through a clever machine. So we say, oh, well, this tumor looks like it might have Lynch syndrome. Does the person have Lynch syndrome? So we take a sample of their blood, we run it through a machine, we look at their DNA readout and we say, oh, they do have Lynch syndrome or they don't have Lynch syndrome. And that's important because we're going to be talking about these methods. So just remember, if you're looking for Lynch syndrome in somebody who's got cancer, the first step is to test their cancer to see if it's got signs of having Lynch syndrome itself. And that's the microsatellite instability and the immunohistochemistry. Okay, why is that important? Okay, why should gynecologists be paying attention to this? This is a crazy graph. I completely get that this is a crazy graph. There's a lot going on here. But what this is just telling us is about endometrial cancer and about the properties of endometrial cancer. And what you'll notice here is that there is a group of endometrial cancers called microsatellite unstable. So these are the cancers that people with Lynch syndrome tend to develop. And why that's important, generally speaking, going beyond a little bit from Lynch syndrome, is this is what we call a survival graph. So it's a Kaplan-Meier graph. It tells us about how survival is impacted by different characteristics. So along the bottom here is how long someone has survived from the time that they got diagnosed with endometrial cancer, or progression-free survival. So how long it takes them until their cancer comes back. And the MSI group is the green line. And you can see that they do very well compared to the yellow group, which doesn't do very well. Sorry, that does do a little bit better. And the red group that does very poorly. So the green group, I beg your pardon, is doing quite well. This is a bit of an anomaly here where they cross over, but mostly we would say that they are quite survivable. So the cancers associated with Lynch syndrome are quite survivable, but also remember that not all the cancers with this characteristic, this microsatellite instability, this Lynch syndrome of the cancer, comes from someone with Lynch syndrome. So finding out if this cancer has that characteristic, even if the person doesn't have Lynch syndrome, is important for us because it tells us that their cancers are better survived, that they are less likely to die from those cancers, which is something that's very helpful for us to know because it means that sometimes we don't need to give really aggressive treatments if that cancer is very survivable. But also it's very helpful for the patient for us to say, okay, you know, this is a horrible time in your life. We're talking about cancer, horrible, scary things. We've looked at your cancer, we've done this test and we found out it's got this characteristic, Lynch syndrome of the cancer itself. You don't, but your cancer's got this characteristic. And that means that cancer is more survivable. This is, again, a very busy thing going on here, and there's lots of things, but what this is showing is that there are drugs that we now have that are targeted to certain mutations. And the one I want to draw your attention to is what we call anti-PD-1. And what anti-PD-1 does is that it's a drug that is very effective in cancers that have mismatch repair. So if your cancer has mismatch repair, this is colorectal cancers, ovarian cancers, womb cancers, whatever it is, we can use this drug, the checkpoint inhibitors, anti-PD-1s. And we know that you get a very good response if we use that drug. So by testing tumours to see if someone has Lynch syndrome, we find tumours that are microsatellite unstable, this characteristic. That means that we can further test to see if that person has Lynch syndrome. But even if they don't, we've identified a tumour that's more survivable and is amenable to different treatments, very effective treatments. So it's helpful to look for Lynch syndrome in cancer, even if we don't find someone with Lynch syndrome. Okay, so the idea here is that by testing, we can target treatments And that's important in medicine because a lot of the things that we give people when they've got cancer are really nasty, really toxic, lots of side effects. So what we want to do is find the best treatment for them with the least side effects. And to use sort of a military type analogy, it's going from your carpet bombing, which is what we often do in cancer, we throw chemotherapy at it, to precision targeted. So if we are looking at the characteristics of a cancer, because we're trying to find out who's got Lynch syndrome, but in doing so, we find cancers with this characteristic that we're interested in, we can move from just throwing any old chemotherapy at people to maybe targeting that treatment more accurately, using a treatment that's less toxic. Okay, let's just talk a little bit about womb cancer. I think womb cancer is one of those cancers that people don't really know about, not really heard about. Obviously, in the Lynch syndrome community, you do know about it. I think a lot of people have a very odd idea that it's not a problem and it's going away and it's not a huge issue. Actually, what we know is that there's an epidemic in endometrial cancer at the moment. Cancer rates are rising and rising and rising. Now, we don't know if that's happening within the Lynch syndrome community itself, but the risk factors for endometrial cancer, namely increased weight, fewer children, reduced use of contraceptives and etc., that is happening in our population. So we can imagine that it's happening within the Lynch syndrome population too. One of the things, again, this is a slide that I don't want you trying to read too much of it. It's just a visual aid to sort of say, okay, what can we test the cancers that I work with for? So if it's an ovarian cancer, we can test that cancer for BRCA. And you've all heard of BRCA. So in ovarian cancer, we're quite happy to, and we can test the cancer for BRCA. And if the cancer has BRCA, we can test the individual for BRCA. So we're already testing for a cancer predisposition syndrome within ovarian cancer. What you won't see there is Lynch syndrome. We don't test ovarian cancers for Lynch syndrome. And where this table has come from is the directory of tests that we're allowed to do on a tumour. This is the NHS funded, NHS allowable tests. So we can test a tumour for BRCA. We can't test a tumour for Lynch syndrome if it's ovarian. That doesn't fit right. Only recently have we been able to test womb cancers for Lynch syndrome too. I'm going to present the work that sort of led to that. Go back to 2015 when I started my research, we weren't even allowed to test womb cancers for Lynch syndrome. We were allowed to test them for these quite random, quite obscure, quite rare genetic mutations, but not Lynch syndrome. Lynch syndrome is completely forgotten about. Gynecologists weren't testing, they weren't talking about it. Okay, so we weren't testing, which means we weren't targeting the people to test for Lynch syndrome, and we weren't finding people that we could use novel treatments on. So things weren't very good back in the day. Okay, so again, just to remind us what the benefits are of testing cancers to find people with Lynch syndrome, because it's not just finding people with Lynch syndrome, there are other benefits too. So remembering that we've got the original family tree showing us that actually gynecological cancers were part of the picture from the very beginning. And what we also now know is that for a woman with Lynch syndrome, the womb cancers are often the first cancer they have. So it's a diagnostic opportunity. What I mean by that is, you know, they're probably going to have the womb cancer first. If we don't test the womb cancer for these things that we look for Lynch syndrome, we miss the fact that they have Lynch syndrome because we never look for it. So we cure their womb cancer because womb cancer has got quite a high survival rate, but we didn't find out they have Lynch syndrome. So we're not looking for the bowel cancers. They then go on to have a bowel cancer and that could be potentially fatal. That's not acceptable. Womb cancer is the first cancer that women often get. And so we were completely missing these women who had Lynch syndrome, saying, well, you're fine, you're good from the womb cancer point of view, and then they went on and got bowel cancers because we never diagnosed them with Lynch syndrome. It's not acceptable. The other thing is, and as you know, is that once we find someone who's got Lynch syndrome, we do what's called cascade testing, and we offer their relative testing for Lynch syndrome too. So by finding one person with Lynch syndrome, on average, we find 3 more people with Lynch syndrome. So there is a multiplier effect. We can diagnose one person who has the cancer, the womb cancer, which hopefully we can cure. We then diagnose them with Lynch syndrome, which means we start looking for other cancers and preventing that cancer risk. And then we test their relatives and we can identify them and educate and prevent, hopefully, or reduce their cancer risk too. How do we reduce their cancer risk? Well, if you've not had a womb cancer or an ovarian cancer, we can offer you risk-reducing surgery. And what do we mean by that? We mean a hysterectomy, a removal of the womb, and a removal of the tubes and the ovaries. And we'll talk about the timing of that and how that should be done. The other thing that we can do is that we know that aspirin is now very effective. The CAP studies have come through and they say that by taking aspirin regularly, we reduce overall cancer risk in people with Lynch syndrome. So if you find someone with Lynch syndrome, we can say, take aspirin. And that's a very easy intervention, a very straightforward thing to do, but very effective. And again, as I was saying before, we can offer people colonoscopic surveillance. We can have regular colonoscopies. I know they're not very pleasant. I know they're awful. And I know that bowel prep is probably one of the most awful things invented. But it does mean that if we're doing that, we know that survival is basically the same as if you didn't have Lynch syndrome from colorectal cancer. If we're looking for these cancers, we find them early, we remove them, we prevent them from becoming higher stage disease, the fatal diseases. And then just going back to that crazy graph I showed you earlier on, by looking for Lynch syndrome, we're also finding a group of cancers called microsatellite unstable cancers. And these cancers have a better prognosis, so it helps us as clinicians, and they are treatable with a different drug. So even if you turn out to have, you don't have Lynch syndrome, by finding a cancer that had this phenomenon, we as clinicians know that we can do different things. So it's beneficial even if we don't find Lynch syndrome. Okay, so in colorectal cancer, since 2017, NICE has recommended that all colorectal cancers are screened for Lynch syndrome. And that was amazing. That's brilliant. So in our colorectal colleagues were screening cancers for Lynch syndrome since 2017. They completely missed out endometrial cancer, womb cancers. They completely missed out ovarian cancers. There's nothing for the gynecologist here. Again, it wasn't our problem. We buried our heads in the sand. Why? Okay, to be fair to us, there was a lot of research around bowel cancer and Lynch syndrome. Some of these studies have got 10,000 people in, you know, they're huge. And that meant that NICE and other people could make solid recommendations on the background of really good research. So they could say, look, if you test bowel cancers for Lynch syndrome, you found that about 3% of them have Lynch syndrome, and that's worthwhile. Tristan from Exeter, who I know that you guys know well, did a really informative study with the HTA, the Health Technology Assessment Group, and they found that it's cost effective to do this. They found that by looking for Lynch syndrome in bowel cancers, that's cost effective. It's a good thing to do, not just because you're finding people Lynch, but it also overall saves the NHS money, or doesn't cost the NHS terrible amounts of money. And that's important for a policymaker. Unfortunately, they're quite cold people. So lots of evidence, cost effective. NICE is obviously going to turn around and go, well, it's a no-brainer. What about womb cancers? Womb cancer is here shown in the red line, bowel cancer shown in the black line. And what this is showing is the number of publications per year with the words bowel cancer and Lynch syndrome. Okay, very crude measure, but I think quite a helpful visual aid. As you can see, colorectal cancer, 200, 300 publications a year. Womb cancer, barely 50. So we just didn't have the information to know if it was worthwhile to do, how to do it, what the impact was. You know, we knew that womb cancers were associated with this, but we just didn't have enough information to work out how to test and what to do. So let's talk now about gynecology. So for all the blokes, this is all going to be a bit queasy. I've not got any shocking up-close photographs, just some nice artistry work. So this is the womb, and these are the ovaries on either side here. So that's what we're going to be talking about. So the first thing that we did, myself and Professor Crosby in Manchester, was basically say, hold on, there's a problem here. You know, well done, NICE, for saying that we should test bowel cancers for Lynch syndrome, but you've completely missed out women. I mean, that seems a bit weird to us. And remember that womb cancers are often the first cancer that women get. So that's the diagnostic opportunity. That's the time when you should find out they've got Lynch syndrome. But we're not testing womb cancers. So this didn't sit very right. And we wrote quite a provocative blog. It's the only blog I've ever written. It's probably the only blog I'll ever write. I'm not really, as tonight demonstrates, not very technologically capable. But it was basically to say, hold on, there is a problem here, and you guys, we need to sort this out. Like, why have we forgotten womb cancers? This is crazy. Okay. And the kind of comeback that we got from our colleagues was, well, hold on, we've got some questions. And no one's answered these questions thoroughly enough. We don't know how many womb cancers have mismatch repair deficiency, i.e. is it worthwhile testing for? Do womb cancers have lots of this? We don't really know. We've got a few papers in there, but we don't really know. We certainly don't have any information in the UK. So if we're trying to convince NICE, which is a UK body, they were like, well, we've got no studies. How many womb cancers are related to Lynch syndrome? Again, NICE was like, well, we don't know that information. The UK, we don't know what to, like, how can you expect us to make recommendations around this when we've got no information? How do we test womb cancers for these things? Do we use the microsatellite instability? Do we use immunohistochemistry, which we talked about earlier on? Should we just do germline testing, so blood tests where they look at the genes on everyone? Like, how do we do it? And also, will people want this? And that's a really important thing. Like, will people want this testing? Are they going to accept this testing? Or are people going to say, no, no, thank you? And one of the other questions, which is a more researchy question, was, if we find out that these cancers have this quality, mismatch repair deficiency or microsatellite instability, this kind of the Lynch syndrome of the cancer, will it mean that they will respond to these treatments that you've talked about, these checkpoint inhibitors, the immune treatments that we think might work? Okay, so the first thing that we did was that we did what's called a systematic review. And what a systematic review is, it basically is whereby you search all of what's been published before and you identify all of the papers that might answer your question. You pull them out of the internet ether and you make these funny looking graphs, okay? And what these funny looking graphs tell us is, if you put all these results together, what's the overall result? So it's like adding everything together and saying, okay, well, if we take all of the information from all these individual studies, the overall number we think is this. So what this funny little graph is saying is, well, what is the proportion, what percentage of womb cancers have Lynch syndrome? And the answer was around 3%. Sorry, which I can't, I've got a funny thing in my, oh no, sorry, I'm covering up my bit. So this one, sorry, is showing how many of the cancers has mismatch repair. So remember, this is if the cancer has Lynch syndrome, not the person. So the cancer has Lynch syndrome, not the person. How many womb cancers have Lynch syndrome? Not the person, the cancer itself. And so we took all these studies that had done testing in that way, and we said, oh, about 26%, about a quarter of them have this thing called mismatch repair deficiency. So quite a sizable number, quite a big proportion have this thing. And remember, if we know about this thing, it might be because the person has Lynch syndrome, not just the cancer. But if we know about this thing, more importantly, it might mean that we can give the patient extra information, tell them about their prognosis more accurately, think about other treatments. So this is an important piece of information. And it's relevant to a quarter of our patients. It's a huge number. The next question, this one, was how many womb cancers are in women who've got Lynch syndrome? So if you were to test womb cancers for this thing to look for women with Lynch syndrome, how many women would have Lynch syndrome? And the answer was 3%. So 3 in 100 people with womb cancer have Lynch syndrome, which is this pretty much almost identical to the number of people with bowel cancer that has Lynch syndrome. So it's not that this is very rare in womb cancer, it's about the same as in bowel cancer. And we're already saying we should test bowel cancer. So surely we should be testing womb cancer too. The problem was that when we looked at the studies that we were getting these answers from, we had real concerns about the quality of these studies. They'd been done in countries whereby a lot of them relied on healthcare insurance. And if you think you've got an inheritable condition, you probably don't want your insurance company knowing that you've got an inheritable condition that puts your risk of cancer up. So you might not take part in the study. You might say, do you know what? If you're testing for this genetic thing, I don't want to know about it because my insurance premiums will go up, which means that people who have a really strong family history might go, actually, I don't want to know, thanks. And they don't take part in the study. So we don't know if all of the people that should have been in the studies were in the studies. The other thing that happened was that often they said, oh, we tested this many cancers and we found these many people that might have Lynch syndrome, but we only tested 5 of them when there were 100 of them. So again, you can't really work out much if they're not testing all the people they should have tested. We also really struggled to find studies whereby they use different ways of testing. So microsatellite instability, immunohistochemistry, these different tests on the tumour that you could do to work out which one's better. So a lot of them just did one or the other, or they did a bit of one and a bit of the other. So you couldn't really work out which one was best. And that was a massive problem because we need to say, well, the way you should test is by using this thing, not that thing. But we didn't know that. And we couldn't tell that from the evidence that was already out there. So what we ended up doing was the PETAL study. So this is a publication in something called PLOS Medicine. It's a journal, and you can Google for this and you can find the paper. It is written in a very sciencey way, I'm afraid. So it's not designed, it's not sort of patient friendly, which unfortunately that's just the way that science is written these days. But it is there, it's free for you to download, you can have a look at it. And this was the paper that tried to address all of those questions. And actually we pretty much did. What we did was that we ran this out of Manchester, and basically anyone with a womb cancer who was coming through Manchester, one of the major hospitals in Manchester, we offered testing for Lynch syndrome. We offered them to have testing on their tumour to see if it had microsatellite instability or immunohistochemistry deficiencies. And then those tumours that had those things, or people with a really strong family history, we offered them germline testing on themselves to see if they had Lynch syndrome. So again, if you Google PLOS Medicine petals, this will come up. And this is the sort of study that a lot of this is based on. So this is what we call the study flow diagram. It tells you how people went through the study. So at the top, we recruited 505 people. In the end, 500 of them went through because 5 of them didn't actually have a womb cancer. We did all of this testing. Don't worry about this, lots of testing. And basically, a lot of people ended up having germline testing on their blood to see if they had Lynch syndrome. And what we found was that 16 of them did have Lynch syndrome. So by testing 500 people, we found 16 people who had Lynch syndrome. The other thing that you've got to remember is that we're trying to work out, again, lots of stuff going on here. Don't worry too much about this. But we were trying to work out which test was better. Should we be using the immunohistochemistry? Should we be using the microsatellite instability? And that's important because for NICE, they've got to recommend something. So do they recommend both? Do they recommend one or the other? They have different costs. They're done by different people. They're quite different tests. And so it's best to try and work out which one works best. And in colorectal cancer, in bowel cancer, people just went, well, they work the same. The immunohistochemistry thing works the same as the microsatellite thing. You know, they're interchangeable. Don't worry about it. What we found in womb cancer was that they're not the same. That the microsatellite instability testing is far poorer at identifying cancers that have Lynch syndrome, and therefore it's far poorer at finding people who have Lynch syndrome. So if you look at the sensitivity, which is a really important thing that we look at to see how well it can identify these things, it's 50-50 nearly. It's a toss of the coin. That is not good enough for a test. Whereas if you look at the immunohistochemistry, it's 100. So this is novel, this is new. We didn't know this. We didn't know that microsatellite instability doesn't work very well in womb cancers. We assumed it would work really well, as it does in colorectal cancers. And this is a funny graph just showing that. So what you want to be is up here. You want to be the triangle and the dot, and the triangle and the dot are immunohistochemistry, this test that we've talked about. And what microsatellite instability is down here. It doesn't work very well at all. So we probably shouldn't be using it in womb cancers. Although we use it all the time in colorectal cancers and bowel cancers, we shouldn't be using it in womb cancers. The next question we asked was, well, do women want this testing, and who should be asking them to have this testing? So when we were doing it, it was myself and Professor Crosby who were doing the consent. We would see women in clinic and we'd say, you know, we would be looking after them clinically and say, look, we've diagnosed womb cancer. Really horrific time, really difficult consultation as always. But then during their care, we would say, do you want testing for this condition called Lynch syndrome? We're offering it. We've got funding to do this testing in this hospital. And would you like to have that testing? Do you know what happened? 99% of women said yes. Again, this was something that I don't think people were expecting. You know, people are expecting lots of women to say, do you know what, I'm having a really awful time. I've just been diagnosed with a cancer. I do not want to be thinking about something else. You know, what is Lynch syndrome? Sorry, I don't want testing for that. Do you know what? 99%, the 2 women out of the 500 who said no were both over the age of 90 and they had no living relatives. And they were just like, do you know what? I don't want this testing. And you can completely understand that. One woman also said no, so 3 in total, but she then wrote back and said, please, would you do the testing that you talked about? So the vast majority of women do want this test. It wasn't the fact that if you ask people say no, they say yes. The thing that we did find, and that's what these graphics down here are sort of talking about, is when to when to ask about testing. So here you can see that it says pre-surgery, on the day of surgery, and post-surgery. So when we consented women for this testing, we did it at different points in their care pathway, in their journey. And actually, if you do it after they've had their operation, and if you do it when they're sort of in that recovery phase and follow-up phase, they are far less likely to become anxious or stressed by the fact that you're asking them about this testing. So we can wait, we've got that luxury, we can wait for them to have their initial diagnosis and get them through that awful point, have their surgery, which is really scary. And then when they've had their surgery and they're recovering, we can talk about Lynch syndrome testing. And actually that doesn't make them any more anxious than anything else. And it wasn't that the people with family histories were the only ones going for this testing or anxious about this testing. That didn't really make any difference at all. So it doesn't matter if you've got a strong family history, you're not going to be super anxious about it, you're not going to be the ones jumping for it. It didn't make any difference. Okay, cost effectiveness is a really important element to all of this, because NICE unfortunately does have to work to costs, and it has to show that things are cost effective. So we did 3 clear studies that showed that if you do universal testing for Lynch syndrome in womb cancer, it is cost effective. So it is something that we should be doing. It isn't a, it does cost money, obviously, but it's not sort of in that scary range that NICE is going to get too obsessed about. And we showed this in 3 different papers, making sure that we were quite sure about our answer. And this is, I think, a really useful thing. And I think people have heard me talk about this before. We did what's called a microcosting study, where we tried to work out exactly how much it costs. And the problem with microcosting studies are that they don't take into account hidden costs. So these numbers probably are a little bit low, but they are helpful to illustrate how much a Lynch syndrome test costs in the care of someone with cancer. And it's 45 quid. Let's just say that again, it's 45 quid. You know, that is I mean, now that we're allowed out of lockdown and allowed into pubs, that is a round, you know, of 6, isn't it? That is what we're asking is spent on each woman who has a womb cancer. That's not asking much. 45 quid. And again, people said, oh, it's going to cost hundreds of pounds, it's going to be da, da, da. No, no, no. And this is why we needed to do the research, is that until you get these numbers, people just come up, you know, people can be very dismissive and you've got nothing to come back with them. So what happened? Well, we then went with all of this information. We came back to NICE and said, look, you said to us at the beginning that you had all of these questions that weren't answerable with the current research. We've done the research. Here are the answers. Please, will you look at this again? And to be fair to NICE, they said, well, absolutely, actually, yeah, we will. And they went away and they did their own systematic review, which is what we had done before, but they, you know, they wanted to look at that again. They included all of our data into that systematic review. They looked at all of the cost effectiveness analysis. They looked at everything else and they said, actually, you're right, we should be testing womb cancers. So this is the new guideline that came out in 2020 at the end of that year, and it says hospitals, you must try your best to test womb cancers now for Lynch syndrome. So we've gone from a situation where we weren't testing to a situation where we are testing. And certainly I'm now in Bristol, so I moved back where my training is after my research years. And what was really interesting, and this was without me saying a word, is that the doctors here got this guideline, they had a meeting about it and said, how do we do this? Now, that little did they really know that I would been beavering away at this, but they were doing that independently, and that is happening hopefully across the country. Now, there is a long way to go, and I'll show you information about that. There is a long way to go, but organically, locally, people are seeing this guideline and going, okay, we've got to do something about this. We've got to start testing our womb cancers for Lynch syndrome. And what we were concerned about is, well, okay, fine. We've kind of answered the first challenge, which we should be testing womb cancers for Lynch syndrome. We should be finding these women who've got Lynch syndrome, who've had a womb cancer that didn't know that they had Lynch syndrome. Then they have the cascade testing, so their relatives get tested. And then you've got women who don't have cancer, but now they found out they've got Lynch syndrome. What do we do about them? What's the care going on with them? And also we wanted to know what's going on in the country about testing womb cancers for Lynch syndrome. So we did this study with Lynch Syndrome UK. You guys provided the vast, vast majority of the information from the patient perspective of what is going on. So I can't thank you enough. This research would not have been possible without Lynch Syndrome UK, without you guys filling out the questionnaires, and without you guys telling us what is happening in your locality. So briefly then, what did we do? We sent out questionnaires to gynecologist, that's gynecologists who specialise in the care of women with cancer, womb cancers, ovarian cancer, cervical cancer, those sorts of things. And we also asked you guys to fill in forms, as well as other people with Lynch syndrome to fill in a questionnaire too. And we compared the results to see what the doctors thought was going on to what the patients, the women, were telling us what was going on, to see if they agreed or if there was a disparity between that information. Well, surprise, surprise, the doctors thought the situation was a lot better than it was. Doctors thought everything was doing a lot better than what patients were actually telling us was going on. So what this map of the United Kingdom is talking about is about surveillance, so gynecological surveillance. Now I'm going to talk to you a little bit more about that because surveillance isn't a clear-cut thing. But we wanted to know, do the doctors think they're offering womb cancer surveillance? What do I mean by that? What I mean by that is, are they looking, so it's like a colonoscopy, are they looking for womb cancers and ovarian cancers on a regular basis, like when we look for bowel cancers colonoscopy? Are they offering that thing? And we call that gynecological surveillance. That can be through an ultrasound scan, it can be through blood tests and an ultrasound scan, it can be through taking a sample of the lining of the womb, and it can be through what's called a hysteroscopy, which is a little camera test where we put a small camera inside the womb to have a look. And what the clinician said is, oh, in Scotland, for instance, it's available. It's available, we're doing it. And actually, when you ask people, they said, well, actually, I'm not getting it. When it says corrected, what that means is that when we take out women's responses who'd had a hysterectomy and wouldn't be suitable for surveillance. So 60% of women who had a womb were having cancer surveillance, but what the Scottish was saying was, well, it's here, everyone's having it. Look at this one. In the Northeast region, it said, well, it's kind of available, it's not available, and only 21% of women were being offered surveillance. Down in my region in the Southwest, doing all right, 70% of people, but still not as much as we thought. Wales is bad. They said, we're definitely doing it, and only 40% of women said, we're receiving it. So there is definitely a disparity. There's definitely a mismatch in care, if you get the pun, between what the doctors think is going on and what the patients are telling us is going on. So there's a long way to go with this. The other thing that was actually really shocking for us was that gynecologists weren't necessarily familiar with the fact that Lynch syndrome increased your risk of ovarian cancer. I'll just say that again. Gynecologists who treat women with gynecological cancer weren't necessarily aware that Lynch syndrome increased your risk of ovarian cancer. What does that tell us? It tells us we've got a lot of education to do. It tells us that there is still education to be done amongst my colleagues about Lynch syndrome and what it actually means. So 15 respondents were unfamiliar with any clinical guidelines describing the management of Lynch syndrome. That means that they didn't know that there were guidelines they could refer to look after these women. They were just doing it off the hoof. They were just following their own intuition. The bit here as well, which I found a bit worrying, was that not all gynecologists thought that we should be testing all womb cancers for Lynch syndrome. The thing that we just talked about, what NICE is recommending. So of the remaining 11 respondents, 11, that's 28%, strongly agreed or agreed with adoption. What we're talking about is universal screening of womb cancers for Lynch syndrome. So 28% said you should definitely be doing this. 55% said we don't care, still not great. And 7 said we shouldn't do it. That's testing womb cancers for Lynch syndrome. These, again, are gynecologists specialising in cancer. It really shocked me that this was coming through. And it wasn't that these people were particularly ignorant. It wasn't that these people never heard of Lynch syndrome, because when we looked at how what we called their baseline knowledge of Lynch syndrome, the people who said that we shouldn't be doing the testing had the same knowledge as the people who said that we should. So it wasn't that these were the ignorant people who didn't know anything about Lynch syndrome. So what did we conclude then? So in this comprehensive survey, so remember you guys filled this in and we got gynecologists fill this in, we basically said that the care that's being doled out isn't consistent, and it really varies on where you live in the country. We also said that gynecologists don't have all the knowledge that they should have around this, and that there needs to be an education stint to this. And we need to, what we say, rationalize the service. What we mean by that is that there has to be a standard of care that we're delivering as gynecologists to women with Lynch syndrome, and at the moment we haven't reached that standard. So there is a long way to go, is what this paper basically showed us, is that there's an education point of view for the gynecologists. There is a service provision point of view. We need to be doing more testing of womb cancers to find those womb cancers that might be in women with Lynch syndrome. And also we need to work out what services we should be offering and standardize that across the United Kingdom. So it's not basically where you live that determines what access to gynecological surveillance, that is looking for the cancers before they're developing, people with Lynch syndrome, are offered. Okay, so are there guidelines? Are there guidelines that gynecologists can turn to? Yes. Again, these are freely available. This guideline is, again, if you search the Manchester guideline on Lynch syndrome and gynecology or something like that, you will find this guideline. And this guideline has actually been written in a way that should be pretty understandable. There is some sciencey words in there and language and stuff. We've got to sound clever somehow, my goodness. But you can go and read this and be like, oh, this is what this is what the guidelines say I should be getting. And you could take this document to your gynecologist and say, have you read this? That is something that's out there for you guys. The other thing is that you've probably heard of the European Hereditary Tumour Group. I know that people from Lynch Syndrome UK attend that meeting when it's happening. It is a lot of fun, a lot of sangria, but also a lot of serious science that goes on there too. And they've produced guidelines as well. Those guidelines are mostly focused on bowel cancer, but they do have a little section on womb cancer and ovarian cancers. And basically they say, follow the Manchester guidelines. So there are two guidelines out there that you guys need to be aware of so that you can take these guidelines to doctors if they're being obstructive and they're saying, oh, no, that we don't do that. And say, well, actually, you should be doing that because look at these guidelines. Okay. So this is where we get into that bit where I'm going to admit there's still things we don't know about. There's some things that we do know about, but there's some things we don't know about. This is something we do know about. Can we time when we do your risk-reducing surgery, that is removal of your womb, your tubes and your ovaries, depending on what gene you have the mutation in? So if you are an MLH1 Lynchy, do you need to have your surgery at the same time as a PMS2 Lynchy? Now, if you don't know about this website, you need to know about this website. So LS Cancer Risk, lscarisk.org. If you go to that website and it is very easy to work, you basically put in what mutation you have, what age you are, and what cancer you're worried about. And it will give you a percentage risk, a cumulative risk at the age that you are. Some of you might not want to know that information. It's completely up to you. But it helps you sort of work out whereabouts your personal risk is. And it's trying not just to say, this is your risk if you have Lynch syndrome. We're cleverer than that. We know that the risks are different depending on what genes you have. So what I would the point I raise this is that if you have an MLH1 mutation, so you're an MLH1 Lynchy, we know that your risk of womb cancer, endometrial cancer, is about 10% at 45 years of age. So that's quite considerable. Okay. That means that we should probably be talking to you about removing your womb, if it's acceptable to you, by about 45. Now, there are little other nuances in there, such as when did your relatives have womb cancer, other risk factors. It should be very personalized when we talk to you about this, but we should definitely be thinking about it around 40, and that means we avoid this 10% risk, 40 to 45. Obviously, this is completely individual. It's completely personalized. It's when you're ready and when you've had your family and etc. But this is the sort of information we're working on. What if you have a PMS2 mutation? What if you're a PMS2 Lynchy? Well, we know actually your risk only takes off at 55. So we might be able to say to you, actually, don't worry about your surgery until you're 50. So we could delay things for you if you wanted to. And again, this is not a rule. We're not going to say you will not have your surgery, but it says to us, actually, your risk of womb cancer is really, really low until you're 50 years old. So if you want, we could hold on. And the reason that's important is that we will probably talk to you about removing your ovaries at the same time. And when we take away your ovaries, we cause what we call a surgical menopause, usually quite a menopause that happens very abruptly, has quite severe symptoms, and is sometimes a bit difficult to manage with HRT. So if we can leave your ovaries in for longer, it means that we're not causing that problem. And we know that if we put someone through the menopause, that they have increased risk of cardiovascular disease, heart disease, and stroke. they have bone disease, they have higher rates of depression. There's lots of things that that can do. So actually, if we know that your risk is really low, maybe we could hold off for a bit longer and wait for you to get to an age where actually maybe your menopause would have naturally started. Okay. And that's what this is showing as well. This is taking that discussion a bit further. If you've got PMS2, if you're a PMS2, Lynchy, do we need to remove your ovaries at all? That's a question. And this is something that your gynecologist should be talking to you about if you have a PMS2 mutation. And the reason they should be talking to you is because the general population risk of ovarian cancer is about 2%. And if you have a PMS2 mutation, your risk is 3%. So it's marginally increased, which might mean actually, do you know what, we could just remove your womb and leave your ovaries in. So there are differences, there are nuances within what your gene is and your risk factors and your family history and all these other things that we should be taking into account. There shouldn't just be a blanket rule, and that's why there's open dialogue between us and you about when you want the surgery, what surgery we would offer, and us trying to give you a bit of expert information so that you can make the best decision for you. Lifestyle. So lifestyle is always a bit tricky because we don't really know, and we're working on a paper at the moment to try and help us a little bit with this, what the impact of lifestyle risk factors for womb cancer and ovarian cancer are if you have Lynch syndrome. So for instance, we know that if you take the combined pill, that your risk of womb cancer and ovarian cancer is reduced. We know if you have a Mirena coil in, that's the coil with progesterone, that your risk of womb cancer is reduced. We don't know if that is true in people with Lynch syndrome. We think it is. And the best information that we have is it probably is. And equally, if you are carrying a bit of extra weight like myself, then your risk of womb cancer goes up. So maybe if you've got Lynch syndrome, that risk also goes up, and maybe we should be talking to you about keeping your weight, in a healthy range. Smoking, obviously we shouldn't smoke. That's the doctor in me. Exercise, yeah, I can hear you all laughing. I walked up the stairs today by myself, so tick. But on a serious note, doing exercise reduces your risk of cancer, and we think if it reduces your risk generally, reduces your risk if you've got Lynch too, and your number of children as well. So we know that the more, I'm not saying have loads of children, my God, I can't imagine having more children. Don't have, I mean, oh, good Lord. But, we know that that reduces your risk too. So that's the reason you have them, you see, that and care when you're old. Okay, the next thing we're moving on to is surveillance. So remember what surveillance is. It's looking for the cancers before they happen. And obviously I'm a gynecologist, so I'm going to talk about womb cancers and ovarian cancers. And the first thing I want to say is, well, should we be offering surveillance? What do the guidelines say? So these are guidelines from the United Kingdom, from Europe, from America. And what they say is mixed. So when the guidelines don't agree, you know that there's a problem with the evidence. We don't know something. And this is where I'm going to be really honest with surveillance, with looking for womb cancers and ovarian cancers and people with Lynch syndrome. We don't know what the best thing to do is. So the UK guidelines said that what we should be doing is seeing people from the age of 25 every year to talk to them about risk reducing surgery, to talk to them about their individual cancer risk, and to talk to them about symptom education. What I mean by symptom education is saying, if you're getting bleeding in between your periods, if you're getting very heavy periods, if you're getting pain, those sorts of things, we want to see you because it might be that you've got a cancer. And then we'll see you urgently and we'll do the tests as needed. We will also examine you when we see you just to check that everything's there, that there's no signs there that would concern us. What we weren't sure about, and we couldn't make recommendations on in the UK, is should you be having an ultrasound scan, should you be having the blood test for ovarian cancer, and should you be having sampling of your womb? Now, it's a guideline, so that doesn't mean that you cannot have these things. It's just that we had to admit that we don't have enough evidence to be sure about this. And that's what a guideline's about. It's about saying, can we be 100% sure or not very sure? And we had to fall down on the not very sure. In Europe, they do recommend having those tests. So having tests to look at an ultrasound scan, to look at the lining of the womb and the ovaries, and also to sample the lining of the womb. Everybody agrees that you should have risk-reducing surgery. In America, again, they recommend that you have some tests, but then also some American guidelines say no. So in America, they're really confused. They don't know which way around you should do it. So thankfully, this gorgeous man, Tristan, who looks a little bit like a Santa Claus cross Viking, He is now working very hard to work out what the current evidence suggests about surveillance. So gynecological surveillance in Lynch syndrome, i.e. does it work? How should we do it? What's the effect of doing it? Does it find cancers? Does it not find cancers? Does it hurt people? Does it not hurt people? And what does it cost? Because that's what NICE will want to know as well. So Tristan is working on this at the moment, and hopefully that study will close at the end of this year, I think. And people from Lynch Syndrome UK are involved in that study. And what is clear is that women with Lynch syndrome want surveillance. We completely hear that. And we're not saying that that's wrong. It is purely that we've got to work out if it works or not. We've got to work out how effective it is and how to do it. We're still in that sort of don't know phase. Lots of stuff going on here. What this is some of the studies that have looked at surveillance. So some of the studies that are published at the moment looking at surveillance for gynecological cancers, womb cancers, ovarian cancers in women with Lynch syndrome. So if you look here, it's how they did it. So TVS is an ultrasound scan. Biopsy is taking a little biopsy from the lining of the womb using a straw effectively. And this is outpatient hysteroscopy. So that is the little camera test that you do with you awake. And the important thing here is if you look over to this side, that even though they're doing surveillance, they're missing cancers. Now, not all of them have missed cancers, but a lot of them have missed cancers. So there's no point in putting people through an outpatient hysteroscopy that can be very uncomfortable and very distressing if it's not going to find cancers. Now, we don't know if it works because what this data is saying is it's mixed. Sometimes it works, sometimes it doesn't. So first of all, we need to look at all of this data in detail to work out what are the good studies, what are the bad studies, why are some studies finding it, why are some studies not, pick all of that apart. And then we might need to think about doing a future study to work out what works. And that is a future direction that we need to look at. We're not quite there yet because we've got a lot to sort of piece together at the moment. We also need to work out if women would be happy to not have surveillance. We need to work out what method we would use. There's lots of uncertainties around this. In fact, we just written an article for the British Medical Journal, which is the journal that all doctors receive if they're a member of the British Medical Association every week, saying that there is uncertainty about this and how we should solve this uncertainty, how we should move forward and find a definite answer. But I just want you to know that the evidence at the moment says that sometimes, even in surveillance, we miss cancers. And again, these cancers aren't early cancers. Some of these cancers are quite advanced cancers. So look, stage 3 here, that is a very far gone cancer. So we need to work this out. As I've said, we need to educate gynecologists, and that's you as well. That's definitely me. The burden is definitely on me, but you guys as well are probably more knowledgeable about Lynch syndrome than a lot of the doctors you interact with. And I'm sure you can tell me stories about some of the absolute car crash consultations you've had where you've turned up and said, I have Lynch syndrome, and the doctor's gone, sorry, what? So we all need to educate. So like I said, one of the ways that we're trying to do this is publish information in the journals and in the educational documents that gynecologists have to look at and have to refer to and make up part of their exams. So the obstetrician and gynecologist is a journal, but it's also an educational resource that's used by obstetricians and gynecologists in the United Kingdom. And articles published in this journal form part of their exams. So all of gynecologists and obstetricians have to sit an exam called the membership exam. And if it's something has been in this journal, then it could be in their exam. So that's why it's in there. The Royal College of Obstetricians and Gynaecologists has just set up what's called a genomics task force, which I'm involved in along with Professor Crosby. And the whole idea of that is to educate obstetricians and gynecologists about genetic disease. And of course, we're there banging the drum very loudly for Lynch syndrome. So the college is trying to react. We have highlighted to the college this is a major problem. People don't know about this. Even the specialists don't know enough about this. This needs to change, because Lynch syndrome is something that we need to be looking for, treating and managing and giving people expert advice about. Okay, the future. I'm going to rattle through this this is me with my lockdown haircut. I tried out some new outfits. I think it worked. I quite like this look. But rattle through this. This is what I'm hoping to try and get sorted hoping to get sorted. That's optimistic. Going to be trying to work on it in the coming years. Okay, lots of crazy colours here, lots of stuff. The first thing is about how your cancers are different to cancers in people that don't have Lynch syndrome. The reason for this is that we might be able to offer people with Lynch syndrome tailored treatments. So when if God forbid they get a cancer, we can think about, well, you've got Lynch syndrome, your cancer's probably going to have some unique qualities, we can use some unique treatments. And one of the unique qualities is that your immune system reacts to your cancer very, very strongly. So all of this brown dotty stuff are immune cells. They're cells that fight infection normally, but those cells can also fight cancers. And they have massively turned up to all of these cancers. So they're there in force. So your body reacts to these cancers very strongly. The cancers then do something very clever where they try to become invisible to the immune system by downplaying certain things like this marker and upplaying this marker. And if we can interfere with that, we can stop the cancer from evading the immune system and mean that it gets destroyed by the immune system again. And this is where these checkpoint inhibitors, these medicines I've talked about a few times, come into play. And what we showed was that Lynch syndrome cancers, so here, have lots more immune cells than cancers that are that have mismatch repair deficiency themselves. That's the cancer has Lynch syndrome, but the person doesn't. They do have an immune response too, but it's smaller. And in cancers that don't have any mismatch repairiness going on, the immune response is even lower. But the Lynch syndrome cancers are a unique group. They have a more strong immune response than the cancers that have Lynch syndrome themselves, but the person doesn't have Lynch syndrome. What that means, what's important there is that a lot of our information about checkpoint inhibitors has come from people with Lynch syndrome being enrolled into studies. And that's an important question because actually in the real world, most of the cancers that we deal with that have mismatch repair, that is cancers with Lynch syndrome, the person doesn't have Lynch syndrome. So a lot of the data we have around how well these treatments work are from people with Lynch syndrome. So we need to think as doctors about, is this also the case in people that don't have Lynch syndrome, but their cancers do? It's a question for us to work out, and that's something that we're going to look into. Oh, this is complicated, isn't it? Lots of bloody colours. It's like a Dulex paint wall gone on crack or something, isn't it? What this is showing is mutations. So it's looking at the cancer's genome, the cancer's genes, not the person's genes, but the cancer's genes. And it's looking at cancers in people with Lynch syndrome versus cancers in which the cancer has Lynch syndrome, but the person doesn't have Lynch syndrome. Thank God I put my teeth in. And what this shows, just take my word for it, it's lots of funny colours. It makes me look super clever. But what it basically shows is that the cancers with Lynch syndrome when the person didn't have Lynch syndrome versus the cancers in someone with Lynch syndrome have different mutations. So they're biologically different. So they not only have a different immune response, but they're biologically different, which means that maybe we should be looking at people with Lynch syndrome's tumours in a bit more detail because they seem to be different to people who don't have Lynch syndrome, regardless of if even the cancer has Lynch syndrome. Probably confusing the hell out of everyone now. Okay. I don't know why that slide's there. Just a little cheeky slide there. No real reason. We can all look at it, take it in. This is how you test a cancer for Lynch syndrome. I've got no reason why that's there. That's just a bonus slide for your enjoyment. Okay, wait a sec. No, back in the room. Right, so at the moment, this is how we test cancers for Lynch syndrome. And you can see we've talked about this immunohistochemistry thing, we talked about this microsatellite instability thing, and there's lots of little boxes here, lots of little arrows, which means it's really, really complicated. And it is. And what it all comes down to really is someone called a pathologist. So a pathologist has to look under a microscope and has to look at some cells, and they have to say, yeah, I think this cancer has mismatch repair deficiency. I think this cancer has Lynch syndrome. The problem is it's not that straightforward. The problem is that it's still opinion. It's still their judgment. It's quite reproducible, as in if one pathologist does it and another pathologist does it, often they agree, but there's still a margin of error in this. So what we're looking at is how we look at this. Look at this, it's like Hollywood here. What we're looking at is how we can make this automated. And one of the clever ways you can make this automated is shining a laser at things. That laser bounces off, but because it's hit a surface, that laser behaves in a certain way. That then goes through a detector which looks at how that laser's behaving. And if you fire it on a Lynch cancer versus if you fire it on a non-Lynch cancer, you get a different signal. We call those signals spectra. And this is like, what is this, like paintballing gone wild, isn't it? Or if you watch Wimbledon, it's like when they do the Hawkeye. They're like, are you out or in? This is what these graphs are very familiar with. What this is basically saying is the red dots, let me just look. The red dots are the tumours that are microsatellite unstable. So the red dots are cancers that have Lynch syndrome, and the blue dots are cancers that don't. And you can see that the red dots all group together up here, don't they? The red dots are grouping together in most of these graphs. That means that actually using this method, we can often identify microsatellite instability in cancers. And because it's a machine doing it, it's not about opinion anymore. It also means it's quicker because you don't need a pathologist, and it's cheaper because pathologists are paid lots of money and a machine isn't. So if we can make this work, it would mean that testing for Lynch syndrome in cancers would become automated. That means it'd be cheaper and it would be quicker and hopefully more accurate. And we've shown that this works in other things. We've shown that we can use this technique to detect endometrial cancer in someone's blood by just shining a laser at it. I think this is crazy. Like, this technology is cheap. This technology isn't fancy. It's very straightforward, but it does work very well. The other thing that we need to do is that we need to start individualizing people's treatment. We need to talk to the person, not about, not the Lynch. We need to talk about the person that sat in front of us. And we need to work out more and more information about what little things gives us more information about that individual sat before us. So one of the things that we found was that the type of mutation you have, not the gene, but the type, enables us to work out what your risk of developing certain cancers is. And the other thing is that we can start to plan when to do your risk-reducing surgery, as I talked about, and what that risk-reducing surgery should be dependent on the type of mutation you have. Are you an MLH1 Lynchy or a PMS2 Lynchy? And that information needs to be tweaked a little bit. It needs to be refined. We need to be finding out more about which women we can say, actually, you can wait a bit, or we can leave your ovaries in if you would like, and which women we have to be like, no, we really strongly recommend you have the surgery now. The other thing that's quite exciting is, believe it or not, this technology was once called vaginal douching. I've just said that live on Facebook. We had to come up with a better name for it because obviously that's not kosher, really. So we called it vaginal cytology, which makes it sound a lot more palatable. Probably not the right word. What this is basically looking at other ways of doing gynecological surveillance. So could we do gynecological surveillance that doesn't involve a small camera being put in the womb or a sample being taken with a small device, because those can be uncomfortable and painful and can be distressing for people. Involved was, and this is not a joke, is putting water in the vagina. So basically think of it like a very fancy water pistol. That water is then collected out, and then the water is examined under a microscope to look for cells with cancer in. And we actually found that this worked pretty well. It was quite accurate at finding womb cancers. So maybe this technology could be used to do gynecological surveillance in people with Lynch syndrome. And that's a big leap. It's a big jump. We're nowhere near that yet, but it's interesting that this is a technology that's recently become available and recently shown to work. And Professor Crosby at Manchester is doing a massive study looking at it in women with womb cancer. And if that study works out well, maybe we could take that to the Lynch syndrome population too. The other thing I want to do, this is a bit about where I'm going to go, is also we've looked to take the lessons we've learned in womb cancer and apply them to ovarian cancer. What do I mean by that? Well, I think that we should be testing all ovarian cancers for mismatch repair too. And I think looking at the evidence that's already been published about this, about 20% of ovarian cancers have mismatch repair deficiency. That doesn't mean that 20% of people with ovarian cancer have Lynch syndrome. That number's going to be much, much lower, but it means that there is definitely a good reason to test ovarian cancers as well for mismatch repair. And in doing so, we will find more people with Lynch syndrome who didn't know that they had it. So there's what this is showing with lots of little stick graphs and things is at the moment, we're not testing people for mismatch repair for womb cancer. If we were to start testing people for mismatch repair, we could find people with Lynch syndrome, which means we could give them aspirin, we could give them risk-reducing surgery, we could tell them about their prognosis a bit more accurately within ovarian cancer, because we know that ovarian cancers in people with Lynch syndrome behave differently to ovarian cancers in people without Lynch syndrome. They are less aggressive, they tend to spread far fewer times, and they tend to be quite localized. That means that they've not really left the ovary. Obviously, if you find someone with Lynch syndrome, you can then test their relatives, and you can also do the same things for their relatives. This is my friend Betsy. It's a bit of a hard slide, this one. Betsy was one of my friends growing up. Betsy and I went to university together. We were really close, and sadly Betsy died when she was 32 because she had BRCA, and she didn't know she had BRCA, and she developed a really aggressive breast cancer, and she died, and that was shit. That was really awful, and she didn't know, and so there was she didn't have breast screening, she didn't have any interventions. She just found out that she had BRCA when she developed a really aggressive breast cancer at the age of 30. That makes me very passionate about the idea that we should be testing people for things like BRCA and for things like Lynch syndrome before they develop their cancers. It seems to me completely mad that the way that we do things at the moment is that we say, you get a cancer and we'll look for these problems. So you get your cancer and then we'll test you, see if you've got Lynch syndrome. Or your mum gets her cancer and then we'll test you for your Lynch syndrome. Why aren't we testing people for Lynch syndrome anyway? Why aren't we offering testing for people who are healthy walking around? We know 95% of people with Lynch syndrome don't know they've got it. We know that 1 in 278 people have Lynch syndrome. Why aren't we looking for it? Why aren't we being proactive? It's crazy. The same with BRCA. What the hell are we playing at? Why are we only looking for it when people get cancers? It's insane. About 1 in 300 people have BRCA. What's the argument here? Part of this is that there isn't enough research around this. There isn't enough understanding. There isn't enough data out there, and that means that you can't really make national policy just on the hoof. But that means that the research community needs to do something about this. The funding bodies need to do something about this as well and fund this. And that's something I'm going to be trying to do in the coming years, because it's, to use my friend, it's bollocks, quite frankly, and we need to sort it out. So currently, you get cancer, you get ill, we test you, brilliant. And what we need to move to is, how about we test you, and then we can make sure that we find the diagnosis, do all of these things, reduce your cancer risk, prevent you from getting a cancer in the first place. Find you, diagnose you, counsel you, offer you risk reduction strategies, get the colonoscopies involved, get the mammographies involved for BRCA, risk reducing surgery when it's acceptable, all of those things, reduce your cancer risk right down. Why aren't we doing that? Completely mad. And actually, if you've got the money, you can do that. You can go online, you can buy yourself a genetics test, Me&23 or whatever it's called, and you can get a BRCA test done outside of the NHS for, I don't know how much it costs, I imagine a couple of £100. You then get a report that says, oh, you got BRCA, and then, hey presto, the NHS has to pick that up, work out what's going on, often have to repeat the test. This isn't a satisfactory way of doing things. It's crazy. Anyway, that's my rant over. That is my talk over as well. I'd like to thank you very much. This is Bristol, which is a beautiful city. Please come visit. It's delightful here. And obviously, I'd love to take any questions or chat to you fantastic people.
Thank you so much, Neil, for that. We have got a question. There's one from somebody on here. Says, my 18-year-old daughter is MSH2. In terms of contraception, is there any evidence that of the pill or the coil, that which one is better than the other as a preventative measure for womb cancer?
The surefire answer is we don't know. So what I will sort of talk about is what we know from people that don't have Lynch syndrome. So if you look at the general population, the Mirena coil, the coil with the progesterone hormone in it, we think is protective against womb cancers in the general population, and we also think it's protective in people with Lynch syndrome. There was a study that was going to be done specifically in people with Lynch syndrome. Unfortunately, that study couldn't recruit, so we don't have any information from that study. But I would say that the coil is very protective against womb cancers in people that don't have Lynch syndrome, and we think it's very protective in people who probably, we think it's probably protective in people who do have Lynch syndrome. The pill is also protective. So I don't think we've got the data to say which one's more protective than the other. The copper coil, the coil without any hormone in, is not protective. So if we're talking about copper coil versus pill, then the pill. And if we're talking about coil versus the pill, then patient preference. The pill might have a more protective effect over ovarian cancer. So that's the only slight difference. But again, all of this is just going on people that don't have Lynch, data from people that don't have Lynch syndrome, as opposed to being sure. That makes sense. I don't know if I've just confused things more.
Well, there's another question here from Linda. It says, I was diagnosed with LS in September 2020, seeing the gynecologist beginning of November 2020, and after geneticist recommended hysterectomy. There is womb cancer in my maternal family as far back as my 2 times great-grandmother. My surgery has been cancelled for the 19th of this month. How long do you normally wait for preventative surgery? I was supposed to have a histoscope in May 2020, but was rushed into hospital with abnormal bleeding, which resulted in kidney cancer.
God, there's a lot going on there.
Yeah.
So preventative surgery should be done by what's called the gynecologist, the doctors that are doing cancer surgery, and it should be done as soon as possible. Now, obviously, we've had a bit of a funny year, to say the least, and our waiting lists are reflecting that, in the fact that we've had to cancel a lot of operations because we've had to shut a lot of our theatres. That is now changing and recovering. It sounds, the other thing is that you've got kidney cancer, which I'm really sorry about. That's awful. If they're doing an operation for that kidney cancer, they could potentially do the removal of the womb at the same time. I don't really know. It's really difficult, these sorts of personal questions about health, because you really, as a doctor, I should be taking a full history and doing lots of other things. I think just talking broadly and not talking about your specific situation, risk-reducing surgery, once it's been deemed the right thing to do, and once you're at a certain age, it should be done as soon as it can be. And if there is delay, then they should be looking at making sure that there's nothing developing in the lining of the womb by doing hysteroscopies. Your situation is complicated by the kidney cancer, so it's a bit hard to give specific advice around that. One of the things that you can do is contact your gynecologist secretary or them directly and just communicate your upset or worries or etc. around those things and see what they can do. If you're concerned about something, go to your doctors and say, I'm concerned about this. Go to your doctors and be very clear that, this needs to happen. And again, you can definitely use the Manchester guidelines to be like, here are the guidelines. This has to happen. This is my risk. Look at my LS cancer risk thing. It's going up and up and up. What are we doing about this?
She's also just added on the bottom of that, I had my kidney removed in August 2020.
So, that would have potentially been a good time to have your risk-reducing surgery as well. And sometimes it's very hard to coordinate those things in a hospital. Bizarrely, it's difficult to get 2 types of surgeon into a theatre. But if you are recovering from your kidney cancer and you have made a full, if you're back to full health now and you're not on any treatments, etc., anything that would delay surgery in that respect, I would get in contact with your gynecologist and say, when is this happening? I've already had a kidney cancer. Let's make sure I don't get a womb or an ovarian cancer, please.
There's just a couple of things, sorry. One from our Facebook page is from Pip, and she said, I'm MLH1 and had my womb removed when I was 39. I'm now 46. When should I think about having my ovaries removed? Thanks, Pip.
So, Pip, that's completely up to you. There is an increased risk of ovarian cancer with MLH1. And we would recommend that you do have your ovaries removed. We would probably look to do that around sort of the age of 45 to 50. So you definitely fall within that bracket. And the thing is now that if we remove the ovaries, there is very good hormone replacement therapy that can support you through any menopausal symptoms you're having. And what's been really helpful for us as gynecologists is that there's now been a development of specialists who deal just with HRT, and they're specialists in the way that they deal with people who've got risk like Lynch syndrome, but also had a history of cancer. And so you can, those people should be available to your gynecologist to consult with about HRT2. Certainly in Bristol, we've got Dr. Kristen Manley, who is our HRT expert and is fantastic, and will give advice on these quite complicated patients, because, you know, Lynch syndrome, risk of cancer, all of these things, HRT, and you need a proper consultation with someone who knows what they're talking about. But yeah, I would recommend that your ovaries are removed, and, you know, by 50.
There was just another little comment there from our Facebook page as well, from Charlotte, saying, what a fantastic presentation. I can't believe how much I've learned in the last hour. Thank you so much.
Thank you.
There's another one in our chat that says, hi Neil, you mentioned sorry, my pronunciation is rubbish, Pembrolizumab, is that what it's called?
Elizabeth?
Yeah, that's the one. For treating wound cancer due to Lynch. Is that widely available in the UK, or is that being used in clinical trials?
So it is, it's not quite at the point whereby I would say it's widely available. What's happening is that individual oncologists, doctors that treat cancers, are using it as a second or third line treatment in cancers that have microsatellite instability that have recurred. So it's definitely available in the UK. It is being used. The nice guidance around it is pretty much almost exclusively for colorectal cancer. So the oncologists that are using it are either sometimes having to make a special case to use it, or going to the cancer specialist cancer drug fund. But it is being used, and it's being used in cancers that have come back or are resistant to treatment and show mismatch repair deficiency. So not widely available is how I'd phrase that. I'd say it's quite exclusive. We are hoping to do clinical trials looking at its use more judiciously. And one of the barriers to that in ovarian cancer is that we're not testing ovarian cancers for mismatch repair. So we can't find the people that would probably benefit from this treatment. So watch this space. Hopefully it'll become more and more available.
Couple of just other things there. Neil, your idea of testing people is good. However, there is an element of people like my sister who refuse to go for Lynch screening. Many thanks for tonight. It was great. And that's from Paul Yorkie.
I agree, Paul, and that's why it is easy for me to say, but actually what we need to do is see what people would do with this. And I asked friends in a pub when pubs were a thing, you know, would you be tested for these conditions? And I was quite surprised that a few of them were like, absolutely not. It's like, why? You know, and that is a barrier to this. But the thing is that people should, in my mind, have the option. And if they don't want to, after they've been cancelled and they've got all the information, if they then say, actually, it's not for me, that's fine. I'm not going to go around swabbing you and taking your DNA and running it through a machine, you know. But at the moment, we live in a situation where there isn't the option. So even if you really wanted the testing, you can't really have it until you've either got a cancer or a family history that's insane or something like that. So that's how we're going to miss those 95% of people that don't know they've got Lynch syndrome and are walking around, is by just by just waiting for them to get cancers. It just doesn't make any sense to me.
Pat from Northern Ireland, LS Northern Ireland, said, fantastic presentation. Thank you so much. There's just another one here. I can't get my head around how a tumour can have Lynch when the patient doesn't have it. In words of one syllable, can you have another go at explaining it? Thanks for a terrific presentation.
So a cancer has its own DNA. A cancer, you've got to think of a cancer like a whole other person inside you. It doesn't share your genetic, it shares some. It's like having a cousin that lives inside you, a really awful cousin. Okay. So it's got some of your genes, but not all of them. So if you think about that, a cancer, your cousin could have Lynch syndrome and you don't. Cancer, because it's mutated and mutated and mutated, doesn't have the same genes as you. It has some of them, but not all of them. So that's how a cancer can have Lynch syndrome, but you don't. It's because it develops its own individual genes, its own individual DNA. We call it its own genome. What we would refer to, we wouldn't as scientists say, or as doctors, this cancer has Lynch syndrome, because then would look pretty silly. We would say that this cancer has mismatch repair deficiency. which is what Lynch syndrome is in a person. It's that the mismatch repair system isn't working. So there are some nuances to that, and if there are scientists watching, a few of them will be like, that's not completely correct. But I think that's a helpful way of describing it, is that your cancer is like an evil cousin living inside you with some of the genes that you have and some of its own genes, and therefore, just like your cousin can have Lynch syndrome and you don't have Lynch syndrome, a cancer can have it too.
Well, she said that was a perfect explanation, and thank you.
Evil cousin. Excellent. I'll remember that one.
And another one there. Do all cancers in that case have a different gene sequence, or are they all the same?
This is where it gets crazy. So, so in a cancer is lots of different cell lines. This is where we're going to get a bit focused. So almost, it's not like just an evil cousin living inside you. It's like an evil city living inside you. So there's lots of different, oh God, how to explain this? There's lots of different cells in a cancer that are different to each other. So when a cancer forms, it is constantly evolving and it's constantly changing and it's constantly mutating and it's constantly doing lots of things, which means that some of the cells go off down one route, some of the cells go off down another route, some of the cells go in a different direction. And what that actually means is when you look at a cancer, if you sample a cancer and you take several different cells from a cancer, those cells might be very different to each other. Now it's all in one big cancer, but they could all be very different in their genes and in their genome. So it's almost like an evil city of cousins. So you take one cousin out and that cousin has red hair, and you take that cousin out and they've got dark hair. And that's how a cancer kind of is. You can sample different bits of the cancer and get very different answers when you look at what genes they have. So that's where it gets really, 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 really complicated, because we all think of cancer as just this thing. You know, you got cancer, cancer's all the same. And actually it's not like that. A cancer is like a load of different people living within a city, all of them with different genetic information, all of them doing their own thing, which is why when you throw chemotherapy at cancer, what often happens is it kills off most of the cells, most of the people in this city, but few of them will be resistant to it. And those are the ones that come back once you stop the chemotherapy. So so a cancer can be very different to you, and then a cancer can be very different to itself, depending on what you sample. So it's a really crazy thing to think about.
Great explanation. There's another quick message here. Fantastic talk tonight. Thank you so much, Dr. Neil Ryan. Very informative. Another one just in our chat group. I think that was from Roberta saying, wonderful presentation. Thank you so much for sharing your time and expertise and for the giggles. Thanks UK for organising. And a final one was from Pip, who you'd answered a question from. Sorry, there's another one just here that just come through. Are you advocating that it would be more cost effective for the NHS long term to offer testing to the general public at a young age to determine a Lynch diagnosis than to wait and treat the cancers when they arise?
I don't know. So with the question about population testing, what you've got to remember is that is at the moment just an idea. And we have no data, we have no information, we don't know how much it will cost, we don't know how many people would find, we don't know how many people would accept the testing, we don't know, all of the things we need to know. So it's just me being really angry about the fact that at the moment it seems the wrong way around. Now, when all this research is done, we might actually find out that no one wants the testing, or that we don't find anybody. So it might not work in any way. So I think the thing that I'm just saying is that we need more research. What we need to do is explore that. We need to explore that question. So I think the question's valid. Certainly we're in no position to recommend to anyone anything. We don't have any information about it yet. So we've got a long, long way to go.
And final one was just from Pip. She said, thanks for the advice and the presentation, very informative, and it made me laugh. Glad we've got you pushing for better surveillance.
Oh,
I think that's actually perfect.
Definitely.
100%.
Lynch Syndrome UK, and like I said, there's a lot of things I've presented here that you guys have supported and made possible. And we certainly couldn't have done the paper looking at Lynch syndrome services across the UK without you guys. And also some of the slides that showed all the immune cells came from women from Lynch Syndrome UK who offered me their wombs.
Yeah, that
Quite a
sounds
crazy
about
idea.
right, actually.
Some of those wombs are what we've changed.
Well, I just want to say thank you so much for agreeing to do this for us. Obviously, we love to see you. We love you advocating for us, and I'm just so grateful to have somebody like you on our side.
Oh, Tracy, anytime. I'm all for Lynch Syndrome UK anytime.
Thank you, and thank you again. Thank you so much. And
Thank
now
you.
you can go and enjoy some dinner.
And a dinner too.
And maybe a gin and tonic, yes.
Yeah, a nice glass of wine or something. Nice.
Tracy, this is lovely to see you. Thank you so much.
Lovely to see you too.
Bye.
Bye-bye.
Bye.
Bye.
Bye.